Thanks very much, Elsa. Thank you for inviting me to come up here and talk. It's only 101 pages, so it's a good Sunday afternoon read, while you're dealing with your alcohol problem, as Ken suggested. These are my disclosures. These are various where I've received monies from various grants and research and drug companies that I've been involved with. In 2015, the College of Psychiatrists, we redeveloped clinical practice guidelines for mood disorders. We'd previously done them starting back in '83, and they've been updated, but it's been a long time since they've been updated before. And so in 2014 and 15, we rewrote them, and we had this step care model for the management of mood disorders, going through a very basic approach where you go through various steps. One morning, Sunday morning, Jim Marley rang me and said, look, we really should update them again. So we went through a process of updating the guidelines, and this took us a couple of years to do. And they were published in January this year, although they went to the press in December. What I'm going to do is go through how we've developed these guidelines and go through a new process we have in the management of mood disorders. Tonight I'll focus on depression, but tomorrow we'll be talking about bipolar disorder. Just some basic facts about depression, which I'm sure you're all very familiar with. It's a very common disorder with around about 10 to 15% of people experiencing an episode of clinical depression at some point in their life. Generally, the onset is before the age of 40, and 40% of patients with major depressive disorder experience their first episode before the age of 20. So it's a very young onset disorder, and it's a disorder that, if we're able to identify and treat it, is very treatable. In the guidelines, we take very much a biopsychosocial and lifestyle approach to understanding mood disorders. That is, we have to look at both the biology and the neural networks that are involved in the final common pathway at the expression of depression, but link it with a very much a developmental perspective, trying to put together both the genetic endowment a person has, and including epigenetic changes which may occur in utero to the developing fetus, an area which I'm particularly interested in, but we won't go into deal with that today. And also the sort of kind of experiences that may put someone vulnerable to becoming depression in later life, and many of those things that Ken has been speaking about. So we have to pay attention to people's experiences of abuse, loss, neglect, domestic violence, and how that will impact on how they're functioning in adulthood. Not only that, but we have to take into account chronic diseases, life-threatening illnesses, their current status in life at the moment, things like employment. That's a big issue, I think, where it may contribute extremely to how people get depressed. We also need to look at how the environment shapes the expression of genes in adulthood, so we can understand how someone becomes depressed. But most of all, something that's quite new in our guidelines is pay a lot of attention to look at lifestyle factors that may be both contributing to the onset of depression and its maintenance. And it's very important that we deal with those factors that deal with maintenance. And I'll come to talk about some of them in a bit more detail later on. What we do, and first of all, in the treatment and management of depression, is a thorough assessment of the person. And that is, we need to take into account their current symptom profile, something just as you all do, I'm sure, in your current practice, looking at comorbid symptoms, anxiety, substance misuse, and so on, any medical comorbidity the person may be suffering from, and what treatments they may have had in the past. We try to bring this all together in a comprehensive formulation of the patient. That's bringing together all the things we've teased apart during the assessment of the patient. This is a detailed process, but a really rich one. If we're going to be able to help the patient, we need to understand all these facets in their life to be able to provide the most appropriate treatment for them. This is essentially our model of treating patients. We need to lay solid foundations for the treatment. And this is where we talk about actions. These are things that we must do. They can't be put off. These are things we must be doing as the foundation of treatment of people with mood disorders and depression in particular I'm going to be focusing on. Then, if those aren't working or they need to go further than that, we have a series of choices. This may be pharmacotherapy or combinations of treatments that we need to be applying. A lot of people will respond very well to that, but sometimes they don't, and when we need to think of alternatives for treatment. And here we look at things like ECT or stimulatory treatments or combined treatments, very complicated treatments. But the majority of patients with major depression will respond to the actions and foundations that we have and the choices that we've got for them. So I'm going to go through those in quite a bit more detail. This is sort of giving a sort of blueprint of our model for treating mood disorders, going through the actions, choices, and alternatives. Let's start with the actions. Basically, we need to look at a whole series of issues that the patient may be presenting with. And these are things we should be instituting at the first assessment. Ensuring that they're getting good sleep. It sounds simple, but sleep has a very powerful effect on well-being. And if people are sleeping poorly, their depression doesn't get better. I remember a young man I was seeing who didn't respond to treatments at all. He was working at TAFE doing a film course, it was a university doing a film course, and he used to be staying up till 3 o'clock in the morning, 4 o'clock in the morning, watching movies, writing essays, then sleep through till 2 or 3 o'clock in the afternoon. So his biological rhythms were completely out of kilter with the external world, and his depression wasn't getting better. He also liked exercising, but because he was sleeping all day, he didn't bother to go to the gym. So we spent a lot of time talking and said, why don't you try to go to bed at, say, 11 o'clock and get up at 8 o'clock and see what happens to you? Come back a week later and said, I've been doing that this week. Doc, I'm feeling a lot better. You know, I'm sort of alive and getting on with the world. And I said, how about some exercise? So he went to the gym. He, for some reason, liked boxing. So he's going to the gym 3 or 4 times a week, and he came back feeling great the next week. But 2 weeks later, he'd slipped back to the old habits. His sleep pattern had reversed, and he was now feeling depressed again and unmotivated. But it just demonstrates that simple strategies, they sound simple, they're very hard to implement, will work and work really well to help people overcome their depression, because it may be the sleep disturbance that's maintaining their depression. Exercise is really important. We don't expect people to go run a marathon straight away. We need to be graded, simple increases in exercise. Getting patients going for a 10-minute walk each day. It don't sound very much, but it certainly improves their well-being. Then you build on that. So going 15-minute walk, a half-hour walk, maybe going for sort of starting to take up some exercise, going to a gym. But we need to be encouraging that with our patients. These are very fundamental actions. And diet. There's a lot of evidence now coming out that poor diet contributes to depression. It maintains depression and may be a contributing factor. By poor diet, I mean a Western diet, junk food. If you can encourage people to have a healthier diet, a Mediterranean diet with grains and fruits and vegetables, not so much fatty food, their well-being improves. Now, these things are very, very easy to say, but they're very hard to implement. And it's hard work. And that's probably why we don't do it with our patients enough, because we've got to work really hard to encourage them to take these actions and to modify their lifestyle. Lifestyle modification is tough, but it's really very, very important. Here are some practical suggestions we put together, just on working on sleep hygiene, is giving them very basic strategies for sleep. You go to bed at a regular time. You get up at a regular time. You have a regular evening meal time. People forget that because it controls our biological rhythms of evening meal time. So you can just get those simple patterns right. Bed is for sleep and for sex. It is not for going on your computer. The blue light from your computer and A lot of the young people I treat, they'll Facebook in bed or do their social media in bed. The blue light from that suppresses melatonin and interferes with your sleep pattern. Plus, you've got all the stress of social media and so on. So it's the worst thing you can do. Phones, TVs, and also should be banned from the bedroom so the person can get a healthy sleep. And I think it's a really important message. And patients often don't think about that. They go to bed and watch TV. It keeps them awake. They don't realize that. Again, we need to be, I'll come back to alcohol use later on because we should be working on that and substance misuse and smoking. Diet is really important, and it's encouraging a healthy diet, not beating them over the head because they go and have McDonald's 3 times a day. And certainly in the western suburbs of Sydney, and it's probably here, there's so much junk food around. And for a lot of our patients, it's easier and cheaper than going to a market and getting healthy foods. And it's a tough ask getting them to change, to move to a healthy diet. These are some practical suggestions about encouraging a healthy diet, is explaining to them what a healthy diet's all about. And then gradually you hope that they'll modify their diet to get a much more, taking on more fruit and vegetables and so on. The next thing we do is to address the kind of things that a lot of our patients are indulging. Drinking too much, smoking, and using illicit substances. Again, this is a hard ask, but when we're seeing them for the first time, this is where motivational interview becomes critically important. Say, look, you're drinking and it's making your depression worse. Try cutting back, try getting into healthy drinking, try stopping drinking if you can. You'll feel better for it. And keeping a very constant message that drinking is going to be harmful for them. The same with smoking. We want to encourage them to stop smoking if possible, but certainly cutting down. With a lot of my patients, I give them a sort of financial imperative. Say, how much do you spend on smoking a week? And it's a lot of money, actually. I can't remember how much a packet of cigarettes is now, but it's a lot. You say, if you put that in a piggy bank, and then you can have a holiday in a couple of months' time. You can even travel outside Sydney. Wouldn't it be marvellous? And so you encourage them that way, give them a positive reason to quit their smoking, and also they'll feel better for it. Similarly, with substance misuse, that really has to be dealt with. We need to be discouraging them from misusing substances. I know it's a hard ask, but it's the thing that may be maintaining their depression and maybe contributing to their depression in the first instance. We also, as a first of one of the actions, we need to be providing some education, psychoeducation to the patient. I've said we need to do a detailed formulation. That formulation we use to explain to the patient, look, these are the reasons that have led to you becoming depressed at the moment. I know you've had a relationship breakup, but the reasons that led to that relationship breakup were these things. And this is what we can do to help you deal with that relationship breakup. Or, you've had these past bad events in your life. We don't need to deal with that now, but we know how it affects you, and we need to be able to help you overcome that in the future. So we use our formulation to explain to the patient what we're going to do to help them improve their life. It also tells us, that formulation, that they also may need psychological treatments. We now recommend psychological treatments should be applied to all patients with depression. I know it's difficult, and access to psychological treatments is not readily feasible, but I'll come to that in a moment. But we also have to do, as psychiatrists, mental health clinicians, we have to deal with some of the basic problems that are contributing to the person's depression. Looking at things like housing. How can you get well if you've got poor housing, or you haven't got housing? I see homeless kids, how can they get better if they've got no place to call home? And that is really hard. We need to help them deal with sort of issues within their family and employment. There's nothing so depressing as being unemployed, I think. And when people are depressed and they're unemployed, they're losing hope, as Ken was talking about. And trying to encouraging them to getting back into the workforce is really hard. And it's very difficult. There's so many of the young people that I've seen, the young mothers I see, where they haven't got employment, they're impoverished, they can see no way out of it. And that's where provision of hope and trying to work with agencies that can actually get them employment is critically important. It's something we really need to be putting a lot more work on, and a lot more work on getting housing for people. It's devastating when they lose their housing. And we also need to be assessing their risk. And Ken's talked about assessing a risk of suicide, which is often very present among people who are depressed. They feel hopeless. And we need to be assessing that regularly to make sure they don't try to progress that at all. We also need to be monitoring their outcome. And the way I monitor outcome is really complicated. I ask them how well they are, and ask them to rate their mood on a scale of 0 to 10, where 0 may be the rock bottom, 10 they're feeling really quite good. I'm not going to say they're manic, but they're feeling good. So I can do that each time I see them. And I can gauge how much they're improving. It's a very simple way to gauge improvement. Psychological interventions are critically important. In our earlier versions, the guidelines say they've got mild to moderate depression, then they have psychological intervention. If they've got a more severe depression, they need antidepressants. We don't think that's the case now. Psychological interventions can help people whatever severity of depression they have. Some people don't respond to it and others do, so it's not the basic decision-making. There are barriers to getting psychological intervention, and they should be overcome. And we should be looking at ways we can make psychological interventions available for everyone. I know there's a limited supply of psychologists and psychiatrists and people who can provide it, but we've got alternatives. It's also what a lot of patients want. And I'll come back to that a bit later on to talk about what patients want. They prefer psychological interventions. They can be used in the acute management of depression, and there's good, very strong evidence that the psychological interventions are effective. Maybe CBT, cognitive behavior therapy, is probably the most widely talked about and most widely used, but other psychological interventions are equally effective. Interpersonal psychotherapy, IPT, is also very effective. And if necessary, we can add antidepressants to it to improve the efficacy of that psychological intervention. Critically important, the psychological interventions are really important for maintenance and relapse prevention. A lot of my patients, when I've seen them, they'll be depressed, they're slipping back, and I've got one guy I see or talk with quite regularly. We do it by phone mostly. He's got a chronic physical illness. He can't work. His life is not terribly good. He worries about things, and he's on a lot of medication, but psychological interventions are the things. You'll say, I'm feeling really hopeless and useless. I don't know what to do. And I said, well, he started making 3D models. And I said, have you made a 3D model lately? He said, no. Well, why not? So I can't be bothered. I said, well, why don't you start again? Decide what you're going to make a model of. Oh, yeah, I might do that. And then we'll build on that. So we go very small steps. Talk to them next week. I'm feeling much better, Doc. He's Scottish. I'm feeling much better now. And because we just made that simple intervention, he's now got a purpose to live. He's taking those small steps. His self-esteem is improving and he's getting better. So that's where the psychological interventions are really important in the maintenance of people when you're treating them for depression. When we say we've got alternatives, we've got a variety of digital platforms. So patients can now do their CBT online on their phone, on their computer screen, or on their tablet. This makes it accessible for everybody. I don't know anyone who doesn't have a phone they can't use to be able to access a digital intervention. And I've put up a list of platforms there. There are a couple that have been developed in Sydney. There's the This Way Up clinic, run out of St Vincent's Hospital, that Professor Gavin Andrews established. You can get a prescription to do the course. It's 6 or 8 sessions for depression. As a clinician, you get feedback about how the person's going. and they tell you about how the person's going and monitoring their improvement using the K10. So they'll tell you what the change in K10 score is after each session. But there are many other digital interventions. You can go online anywhere and put online CBT, and you'll find hundreds of platforms coming up. Some of them are paid for, some of them aren't. The better ones have therapist support, so you can actually contact a therapist or ask questions online, and you get a response to be able to help the person overcome their depression. There's some positive strengths and weaknesses. Obviously, accessibility. It is also high fidelity, so it sticks to the cognitive behavior model, and so they don't stray off. And as Gavin Andrews used to tell me, so you don't go and ask questions about the person's aunt or their cat. That's a disadvantage, because I had another patient who was really depressed and her dog got injured, and that plummeted her getting much worse, and asking about the dog was the critically important thing I could do to help her at that time. So the disadvantages in having a high fidelity. Let's move on to getting into the area of choices, where we need to look at choices for treating of depression. And this is where we come to antidepressants. We don't recommend any particular antidepressants or give indications for particular antidepressants. We state that psychological treatment should be available for everybody and should be the basis of all treatment, the foundation of all treatment. But some patients, they do need antidepressants. And we need to be thinking about an antidepressant and selecting on a number of different parameters: efficacy, tolerability, patient preference, and the clinical profile. So I'll go through each of those, and a lot of the information we have about efficacy comes from this thing called a network meta-analysis run by Andrew Cipriani and his group from Oxford, where they compare all the antidepressants with each other, all statistically, and you get a rank order of the antidepressants. And so you can tell which are the most potent ones. On the left-hand side in column A, the further to the right, the graph shows the most potent antidepressants. So in this one, we can see that amitriptyline is the most potent, and at the bottom, we've got the least potent or least effective one is reboxetine. On the other side, we're looking at acceptability and how acceptable is an antidepressant. This was calculated by dropouts from the trials, and these are all clinical trials on dropouts. So the most acceptable was agomelatine. That was the one that got least dropouts. People could tolerate it the best. But this creates for us a conundrum, and that is the most effective treatments are the least tolerable. And as you get to least effective, they become much more tolerable. It's a real problem. So how are you going to choose which antidepressant is going to be the right one for your patient? You've got this conundrum going on. You've got to select it all out. So we started to look, in trying to choose this, at very specific things about tolerability of antidepressants and their side effect profile. And we grouped the antidepressants into certain, so the ones that have least effect on the heart or in the red, the least sedation in the yellow, the least weight gain in green, and the least sexual side effects in the blue. Now, the reason we target those are these are the problems that patients come to us with. Again, I treat young women with perinatal mental disorders, and you say to them, you know, I'm going to put you on antidepressant. Am I going to put on weight? That is the big concern. It's a concern with a lot of patients. Or am I going to be sedated? Am I not be able to function? Or I can't sleep. Will I be able to sleep with this antidepressant? Will it agitate me? So we need to be listening to those concerns and trying to select an antidepressant that will fit in with that. We also have to look at the time in which the person's on an antidepressant. So initially in treatment, we need to make sure, because many of our patients have comorbid conditions, there aren't going to be any interactions with other medications the patients have. So that's an important consideration. Another thing we thought about was that, and I'll come to it later on, about 40% of patients don't respond to the first antidepressant they're treated with. And so you've got to change over to another antidepressant. So if you put them on an antidepressant with a long half-life and it's difficult to switch, let us say you put them on a monoamine oxidase inhibitor. If you stop that, you've got to wait 2 weeks before you can start another antidepressant. And it's not going to be very helpful. So you want to be able to have ease of switching as a major consideration. So that's why we put that in as an important consideration. Often in the early stages of treatment of depression, this is where suicidality might increase. And so you want a medication that isn't going to be something that they can take an overdose of. And so we want to make sure they're going to be safe in overdose in the early stages of treatment. And so we've listed the antidepressants we think are safer in overdose. None of them are absolutely safe, but they won't kill you if they're taken overdose. And then we've got the ease of switching. The next thing we need to be thinking about is what patient preference is. And there's really good evidence now that if patients want to be on an antidepressant and they're put on an antidepressant, they do okay. If they want to be on a psychological treatment, they're put on an antidepressant, they don't do as well. And this is sort of a very basic study where there was a match between what the patient wanted and what treatment they got, showing that the outcome was worst for the patient where there was a mismatch. These are changes in depression scores. And the top line, when the patients aren't getting the treatment they want, they do the worst. So their depression scores remain high at the end of treatment. If there's a match between what they want and what they get, then they do much better. And we really need to listen to that. Again, this in choosing an antidepressant, my patients will say, look, my auntie took antidepressant X, and she had horrible side effects. Don't put me on that. And I know if I put her on that, she'll get horrible side effects. Another terrible story. A patient of mine should be put on to metazapine, which puts on a lot of weight. But GP put her on it, and she wasn't responding, but she hadn't been on the right dose. And I said, look, this is an antidepressant you'll put on weight. She said, yeah, I know, but my son was on it, and he did really well. So I reluctantly left her on it, and she put on a lot of weight, and she was a largish lady to start with, and she put on about 5-7 kilos, and it was really quite unhealthy. But she said, look, I'm feeling great. Don't take me off this antidepressant. I can put up with that weight gain. So you need to listen to what they're saying. I'll put her on something completely different. But she took one that she knew would work, and it helped her, and that's really important. There's been another study. This is a really interesting study. It's done in America where patients were given the options of what they wanted to be on. And they were randomized to either cognitive behavior therapy, escitalopram, or duloxetine. First point, they all did equally as well. So CBT did as well as duloxetine, did as well as escitalopram. That's a really interesting finding. But then they looked at what they had preferences and so on, and their outcome. This is by the different races. But the key thing is when they had a strong preference for a particular kind of treatment and they didn't get it, they didn't complete the treatment course. So they walk with their feet. If they say they want psychotherapy and you give them an antidepressant, they stop taking the antidepressant. The outcomes were pretty similar, but they did better if they got the kind of treatment that they preferred to get. And the reason that's important is they will remain adherent to the treatment. And adherence is one of the biggest problems we have. And we need to explain that in part of that psychoeducation of the patient, that I'm putting on an antidepressant, you need to take it every day, and you need to be on it for about 6 months, at least. And then they come back a week later and you say, you're taking it? Yeah, Doc, I take it the days I'm feeling miserable. You think you've got to go back to the beginning and start all over again. It's really important. And if they've got negative attitudes about the medication, they've got adverse side effects, they won't take it. And this is a chilling slide. This is taken from the Medicare data. The majority of patients, 50%, don't pick up the second prescription. The time for 50% of patients to remain on an antidepressant. With venlafaxine, it's 3.5 months. With an SSRI, it's 3 months. And other medications, it's 2 months. So we know that about half of our patients aren't going to be taking the antidepressant we prescribe for them. And you wonder why they're not getting better. And that's why we need to be providing that good psychoeducation, thinking of their preference, and choosing a profile of medication that's going to be suitable for them. So look, what are our choices? So we put all this together, and we came up with these series of choices. And the ones we thought as our first choice antidepressants, these are moderate efficacy, good tolerability, were escitalopram, vortioxetine, and agomelatine. These are probably the good first choice antidepressants for those, except 2 of them aren't on the PBS, unfortunately. If they've got private insurance, it's reasonable, but they're not on the PBS. Only escitalopram is on the PBS. If they're not responding to that, then you need to go something a bit more potent. We've got venlafaxine, mirtazapine, and bupropion. Sorry, these international guidelines, bupropion's not available as an antidepressant in Australia, but it is available. We've taken one of the antidepressants from each class. So we've got each of the classes are different, increasing effectiveness as we move along the line. And our final choice antidepressant is amitriptyline. That's the oldest of the antidepressants and probably the most effective one. I certainly find it really effective, but its side effects are not well tolerated by patients with postural hypotension, dry mouth, blurred vision. But for my seriously depressed patients, it's a very, very good antidepressant. We also need to try and select according to the clinical profile of the patient. And so if they've got predominant anxiety, we'll give them SSRIs or SNRIs. If they've got some cognitive difficulties, so the older patients, then duloxetine and vortioxetine have probably got the best match that clinical profile the best. If they've got sleep disturbance or insomnia, mirtazapine, which is really sedating but puts on weight, or agomelatine. If they've got fatigue, the SSRIs, I won't say bupropion. If they've got pain or painful syndromes associated, maybe arthritic pain or neuropathic pain, then duloxetine and the tricyclics. For severe depression with melancholia, characterized by psychomotor slowing and diurnal mood variation, we really go for the tricyclic antidepressants. If they've got psychotic symptoms, then an antipsychotic needs to be added. And if they've got atypical symptoms, MAOIs. I think the MAOIs are terrific antidepressants if you can get them. These are really anxious patients get them. And last year, 2019, sorry, I've forgotten about 2020. 2019, couldn't get supplies of tranosapramine. And my most anxious patients are the ones that were on it. And they were petrified, and they were going around chemists all around Sydney trying to buy the last stocks they could get. And then we had to get a special scheme, and it was brought into the country at an enormous cost for them to get it. And I think it was under threat again just recently, and it may still be under threat as the pharmaceutical companies aren't producing these antidepressants, but they're fantastic antidepressants. Just going back to looking if we're not getting those responses with antidepressants, we've come up with a series of strategies with an antidepressant if they're not working appropriately, which we call the Midas model. The Midas model is really, we're looking at, first step, we put them on the medication. So we've gone through all the psychological treatments, they're not getting better. So then we put them on a medication. If they're not responding adequately to that, then we've got a series of steps you can take. You can increase the dose of the medication. And we don't recommend increasing the dose above the recommended levels of doses, or not much above the recommended doses, because there's not much evidence of increased efficacy. So if you've got someone on fluoxetine, say, and you're going to 60 milligrams maybe, but 80, probably not much efficacy. And it's just doing no good. I saw one young woman who was on 850 milligrams of venlafaxine a day. I think she was going to the chemist every day to get a new prescription. It didn't do her any good at all, but it was impossible to get her off it. I mean, she was really stuck on it, and whoever prescribed it to her did her a terrible disservice. So you can increase the dose. So that's the I from the Midas. If that doesn't work, then you can augment the medication. And we can augment with a number of different drugs you can use. You can use lithium, which is my favorite one. It works really well. If it's going to work, it works in a week. If it's not going to work, you don't bother. If it's not helped in a week, you stop it. Or you can augment with atypical antipsychotics or second-generation antipsychotics. The one that seems to have done most widely used is olanzapine. The problem with that is the weight gain. Again, I had a patient during COVID she was the one whose dog got injured, and she slipped into this quite severe melancholia. We're thinking of ECT, but couldn't get her into hospital for ECT, so I augmented with lithium. She didn't respond. Then she augmented with olanzapine. She put on 8 kilos in 2 months. And she was, again, quite a big girl before then. And this was devastating for her, so I've had to change augmentation strategies, and I'm augmenting with something else now. She seems to be going okay. But augmenting with olanzapine has that downside. There are other anti-agents you can augment, but they're not TGA approved, things like brexpiprazole and aripiprazole. Again, you get problems with akathisia with that, so you've got to monitor that very, very carefully. If those don't work, then you can switch antidepressant. And again, the evidence here is very interesting. There's not much evidence whether switching from one, say, SSRI to another, or switching from an SSRI to an SNRI, whether there's any advantage in switching within or outside of class. There's no evidence to suggest or support either of those switches. And sometimes switching can be very helpful. Again, you've got to taper down the medication and up-taper the medication. If none of that works and you've done that loop a couple of times, then you may be looking at physical treatments, and in particular ECT, which I'm not going to be talking about. There's this article in The Guardian last week. I don't know if any of you saw it. It was just been a Cochrane review published on withdrawal from antidepressants. And they were very critical of guidelines in withdrawal, and they were critical of our guidelines, except they were the 2015 guidelines. They hadn't bothered to read our 2020 guidelines, where we've gone into a lot of detail about antidepressant withdrawal, what we call discontinuation and withdrawal symptoms. And there are a whole plethora of these symptoms. They are common. Probably 40% of patients will have some discontinuation and withdrawal symptoms. We need to take them very seriously. And the critical thing when patients come off an antidepressant is teasing out whether they are going through discontinuation withdrawal symptoms or having a relapse of their depression. So you need to take a very careful history, what symptoms and they're reporting. I've listed here all the kinds of symptoms that have been reported and described for discontinuation symptoms from the SSRIs, and particularly SNRIs as well. Or you can remember the simple acronym of FINISH. Flu-like symptoms. So I tell them, you're going to feel like you had the flu. You're going to feel pretty rotten for a few days. And it can be weeks. There have been even reports of months people have had discontinuation symptoms. Insomnia, nausea, imbalance. They talk about this sort of shakiness and can't stand up properly. Sensory disturbance. They talk about weird sensory experiences, flashes through their body, electric shocks, all sorts of things patients will tell you if you ask about it. You've got to ask about it. And hyperarousal. So it's a pretty miserable state of affairs. And it means you've got to withdraw patients very slowly from antidepressants. I can't remember if I put the slide up here. They need to be withdrawn, and the way it's been recommended by the Dutch group, who are the experts in this withdrawal, is using a hyperbolic function. And that is you drop the dose. If you say on escitalopram, you drop down to 10 milligrams of escitalopram, then you drop it incrementally smaller dose. So you may go to 7.5, then 6. Then 5, then 4.5. And each of those steps would be for a week or two. Except we can't break our tablets up that small. The Dutch have got, you can get drops for all the antidepressants. They can take 1 drop or 2 drops or 3 drops to come off in that hyperbolic function. So we've made sort of very clear recommendations. Recommendation 1. When you start someone an antidepressant, tell them they might get withdrawal symptoms when they stop taking it. Then they'll say, well, are they addictive? And you say, no, they're not. There's a medicine that's being taken away and our body responds to that. It doesn't mean you're craving more, but you are getting withdrawal symptoms from it. It means never stop them abruptly. If you want to come off your antidepressant, talk to your doctor about it and have a withdrawal plan taken away. And then we think the dose should be tapered slowly. And the minimum is a week between each increment. So you drop down to the lowest minimum dose, and let's say with escitalopram it's 10 milligrams, stay on 10 milligrams for a week, then go down to 5, then stay on that for a week, and then go down to 2.5. You can actually break them down to 2.5 with great difficulty in a razor blade. And the patients will do it because you've told them about it. At the same time they're withdrawing, you need to watch out that they're not getting re-emergence of their depression again. And the key symptoms here, anhedonia, they're not getting any pleasure or enjoyment from things. Their self-esteem is going. They may be getting the sleep disturbance again. They may have psychomotor slowing. So you've got to watch out for those symptoms. The key difference with withdrawal symptoms, you put back the antidepressant and they get better. If with depression, you've got to try and start retreating the depression. It doesn't respond very quickly. It takes a while for them to get the response to depression if they're having a recurrence of the depression. So, I think I've finished almost on time. So just in summary, we need to have, following our diagnosis and a detailed assessment and formulation, we need actions that need to be undertaken. That is addressing lifestyle and psychosocial factors and providing psychological treatments. We then, if that's not working, need to choose an antidepressant, and that choice of antidepressant is based upon efficacy, tolerability, patient choice, and the clinical profile. I think I'll stop there.